Yes, I think I'll get started. I'm Sarwat Umer. I'm going to talk about hemophagocytic lymphohistiocytosis today. Hard to say that word, very long, so I think we'll use HLH during the rest of the talk. But that's an important topic. When I started preparing this topic for my grand round, I really wanted to discuss it because it has wide implications. We need to know about HLH in different forms. We see that in pediatric population. I also see these cases with HLH in patients with juvenile idiopathic arthritis, but also these patients can present at any age. So it's a very relevant topic for internists. So let's talk about HLH. When I'm saying immune system unwilling to quit, something that you can say pretty much for most of rheumatology conditions I deal with, but in this you will notice that immune system is at the worst behavior to the point that if we don't identify these patients early, there is high mortality. And we can't go for, sorry, okay. So learning objectives. By the end of this talk, we should be able to define HLH, describe various clinical features of hemophagocytic lymphohistiocytosis, and we should also be recognizing when a patient have that fatal disease, so we can design an appropriate evaluation and treatment plan. I have no conflict of interest to disclose. I'll start with a case. This is a pediatric case, and I picked this case because it had more typical presentation. So this is a 15-year-old African-American female who has no past medical history except essential hypertension, who presents with 2-week history of intermittent high-grade fever, as well as pleuritic chest pain. On her exam, the only remarkable thing was tenderness on the wrists, and patient had a maculopapular rash on her upper arms. I keep going the wrong way. Her labs showed that she had high SID rate, CRP, leukocytosis, anemia, thrombocytosis, but negative autoimmune workup with negative rheumatoid factor and negative ANA. She was found to have acute pericarditis. Her echo was normal except a trivial pericardial effusion, and she was treated with aspirin and colchicine. Cardiology was involved in the care during that time. Patient pericarditis improved, but she continued to spike fever. This is the time when rheumatology was consulted because of her recurrent fevers. When I saw the patient, recommendations were made to obtain LDH, ferritin, and triglycerides. Patient LDH was elevated. You can see the number there, 569. But this patient had markedly elevated ferritin, around 53,000. And this patient was started on high-dose oral steroid. And initially, she had a good response. I did not start her on IV steroid at that time because she has uncontrolled hypertension, and we just started oral steroids. And patient had improvement, and her fever resolved. But this fever recurred in 2 days. And I was anticipating that this patient will break through the dose of steroid I'm using. And her fever pattern changed. It changed from the intermittent pattern to a persistent pattern. Patient had abrupt drop in her SID rate. So she presented with a SID rate of 120, and it acutely dropped to 30 now. Patient developed low fibrinogen, and she went in profound hepatic dysfunction. She had liver failure to the point that her transaminases were ranging in 5,000 to 7,000, and she was transferred to PICU. I will tell you rest of the story about this patient, what happened next. But this is a patient who's presenting with HLH. So while we'll talk about HLH, we're going to discuss what it is. We're going to discuss what is the classification. We're going to discuss how long we have known this disease, but there is still limited understanding, and this disease is not well discussed among internists. What is the pathophysiology of the disease? What are the clinical features of this disease? How you diagnose and evaluate those patients? What would you do for management of those patients? And at the end, a brief summary, so we have some take-home points in our mind. So basically, HLH is a condition in which you have uncontrolled systemic inflammation, and it is driven by lymphocytes which are activating the macrophages. So classification-wise, patients can have primary HLH in which they have a genetic mutation, a deficiency by which they do not handle immunologic triggers very well. That was first described. The first case of familial HLH was described in 1952. Secondary HLH, which is called acquired or sporadic form, that can happen without genetic mutation. So far, the understanding is without genetic mutation, although patients may have some heterozygous mutation there. And there is a clear trigger that might cause that secondary HLH. The trigger could be a viral infection. That's why it's very important for our infectious disease colleagues. It could be autoimmune disease, rheumatology conditions that I usually deal with, or malignancy. So oncologists will also see those patients in their practice. Another term that some of are more familiar is macrophage activation syndrome. That's a term which is used for the secondary HLH when it happens in the setting of rheumatology. And patients can have either juvenile arthritis or lupus or other rheumatology conditions and present with HLH, or it's called macrophage activation syndrome at that time. So a little bit about the history of the disease. As we said, 1950 was the first case that was described. 1970, there was more recognition that it can be a familial form or it can have some triggers like viruses, malignancies, or autoimmune condition. In 1980, the term was coined called Hemophagocytic Lymphohistiocytosis. 1994, there was an international clinical trial by which there was a consensus on the definition of this disease. 1999 was the first gene defect which was identified called PRF1 or perforin gene defect. 2004, there was another international consensus on HLH based on the international trial. And by that, we have diagnostic criteria for this rare condition as well as the treatment protocol was further defined. So let's talk about the pathophysiology of this disease, what's happening to those patients. So basically, we said a syndrome of excess inflammation and tissue destruction, which is happening secondary to immune activation. So macrophages, what is the job of macrophages when there is body tissue which is infected, which is damaged through the immune system, or which is damaged through the malignancy? Macrophages are supposed to take it and present it to these natural killer and cytotoxic lymphocytes. And they are supposed to remove those activated macrophages. So patients who have either a genetic defect, or in some patients it happens just with one-time trigger, they can have excess of that activated macrophages, and these cytotoxic cells are failing to control them. So in HLH, natural killer cell and cytotoxic lymphocytes will fail to eliminate those activated macrophages. The end result would be multi-organ dysfunction. There can be damage to many organs because of that. How do natural killer cell and cytotoxic cell, lymphocyte cells, they remove the activated macrophages? One of the things they need is perforin-dependent cytotoxicity. And that requires a series of steps in which there is creation of pores in the membrane of the macrophages, and lymphocyte will release granzymes. Those are the enzymes which are supposed to digest and take care of those activated macrophages. And there are serial genes which are involved in this whole process. So patients who are genetically deficient or mutated, they will not have all those genes. They will not have all those steps properly in place. That's why they get into HLH. So we know by genetic studies now that these are autosomal recessive genes we're talking about. And we will test patients with HLH if they have very early onset disease presenting in infancy, or under age 2. We'll test patient when they have recurrence. We'll test patient when they have family member with this condition. And the few gene mutations that we know are more common in different ethnicity that include PRF1, which is common in African American, 98%, and Hispanic, 71%. UNC13D, other name is MUNC13.4, which is common in 47% of Caucasians and 17% of Hispanics. And then the other mutations like STX11 and XTXBP2. This is just a small diagram explaining that perforin-dependent cytotoxicity, and you can easily see there are different, I'm trying to find my pointer in this. So you can see that there are different genes which are involved in this whole process, and any of them can be defective, which can lead for familial HLH. So what happens when these cytotoxic cells and NK cells and macrophages are overactive? They will cause a big release of or a storm of pro-inflammatory cytokines. The cytokines which are elevated include interferon gamma, tumor necrosis factor alpha, interleukin 6, 10, 12, and soluble IL-2 receptor CD25, something which can be measured through the last one can be measured through the immunologic testing. Another thing which is the hallmark of the disease is hemophagocytosis. So what these activated macrophages will do, especially in the bone marrow, that it will start engulfing host RBCs, WBCs, and platelets. And when you get a biopsy on the immune tissues, which could be possibly a lymph node or bone marrow, you may see that hemophagocytosis. It can be also seen in liver and spleen, but these areas are difficult to get biopsied. One word of caution is that hemophagocytosis in bone marrow can be missed. So you can pick the cases with HLH 60% of time with bone marrow biopsy, but there may be patients who have evolving HLH and you still missed after getting a bone marrow biopsy. So you have to maintain a high index of clinical suspicion. This is how hemophagocytosis look like. And in this picture, you can see the red arrows are pointing toward there is engulfing of the RBCs by macrophages, and the black one is showing platelet counts. Platelets are being engulfed by the macrophages. Let's briefly talk about the triggers, what might cause HLH in the form of secondary HLH. So infections, when we talk about infections which can trigger HLH, that will include some of the common viral infections we all know of, EBV, CMV, and adenovirus. Although you can see a host of other organisms, including H1N1, HIV, and different bacteria like Brucella, gram-negative bacteria, TB, different parasite and fungi can also trigger that in susceptible hosts. Malignancy, so leukemia and lymphoma, and some solid tumor, you can see patient presenting with secondary HLH. Rheumatology disorders in which you see HLH, the typical setting is either a lupus patient, and we are all well aware of lupus patient in our institute. But something that I want you to know more about is Still's disease. And Still's disease present in kid as systemic onset JIA, and in adult is called adult onset Still's disease. These are very inflamed patients. And I want to emphasize here that juvenile idiopathic arthritis have 6 subtypes. And all of them do not have systemic inflammation except systemic onset JIA. Those patients are very inflamed. They have high SED rate, high CRP, leukocytosis, anemia of chronic disease, thrombocytosis, and usually their ferritin is in couple of hundreds to few thousands. This is how these patients usually are. They have fever, and the fever comes usually in a quotidian pattern. It comes at time of the day. And that time, patients can have a evanescent, non-specific rash. This is a typical patient with systemic JIA. When these patients develop HLH, secondary HLH, their fever changes pattern and it becomes persistent. They can have an abrupt drop in their SED rate, as my patient did, and that's related to that these patients have low fibrinogen level. And then these patients can start developing high LDH as well as very high ferritin, which is the marker of macrophage activation. And this condition can present in adult patients the same way, and it's called adult onset cell disease. And these patients are the ones who are much more at risk of macrophage activation syndrome. Different immunodeficiency syndromes can present with HLH2, something which is beyond the scope of my talk, and I don't want to tell about all immunodeficiency syndrome today while we're discussing it in medicine grand round. So, but these can also trigger HLH. This is just a picture of a patient with systemic onset GIA. So if you see a patient, an adult, who told you that they have had juvenile arthritis as a kid, and they tell you that they used to have fever and rashes with that, that's the patient who have systemic onset GIA. And the non-specific rash look like in this picture, as well as the picture of the hand is showing the active arthritis. So I should just notice this arrow. I'm going to just move it on the side. Sorry for that. Okay. What are the clinical features of patient with HLH, primary versus secondary? Patient will present with fever. You will see at least somewhere between 95 to 97% cases there is hepatosplenomegaly. There may be extensive lymphadenopathy. These patients can have neurologic symptoms, something which makes you think of bad prognosis, because those patients who have renal dysfunction or neurologic dysfunction, they are pretty advanced in their disease. Neurologic abnormalities could be encephalopathy, it could be seizures, it could be ataxia, or patient can present with a condition called PRESS, which is posterior reversible encephalopathy syndrome. And we know that present with patients with altered mental status and even seizure, and you see vasogenic edema on the MRI on those patients. Some other things that can happen in these patients are pretty sick. Many times I have seen patients with HLH in ICU. So these patients can develop a full-blown acute respiratory distress syndrome, and they may be on a ventilator. These patients can have severe hypotension, and they may be on the vasopressors. Renal dysfunction can happen, and the patients can have different kind of skin rashes, which can be anyway from the evanescent kind of rash I showed you earlier to erythroderma, edema, petechiae, or even purpura. What is in the differential diagnosis of that patient? It's going to be a broad differential diagnosis. You're trying to rule out a lot of infections, you're trying to rule out malignancy, and you're trying to rule out a lot of rheumatology conditions in these kind of patients. So some things which definitely need to be taken into account at that time is TTP, thrombotic thrombocytopenic purpura, sepsis, drug reactions, as well as malignancy. How do you evaluate those patients when you start suspecting somebody has HLH? You will start first with the baseline CBC, and you will see these patients have cytopenias, profound cytopenias, anemia, thrombocytopenia. One word of caution about that is that my patients with systemic GIA, when I see them going toward macrophage activation syndrome, they change their leukocytosis to a normal white count. They change their thrombocytosis to a normal platelet count. And it's a very sudden change with persistent fevers. So although they are having normal counts, they are relatively cytopenic because they had very high white count and platelet count to begin with. But if you're seeing a patient with lupus or a patient who have had some bone marrow issues to begin with, they may be having a low normal white count and platelet count and start developing more cytopenia. Patients can have elevated liver enzyme, as my patient did, and AST, ALT, GGT, LDH, and bilirubin all can be high. Coagulation studies are important in these patients. The more hepatic dysfunction happens with these activated macrophages, these patients are going to start showing a DIC-like picture. So you will see their PTT is prolonged, their INR is prolonged, D dimer is high, fibrinogen goes low. And we already discussed that SED rate can abruptly drop in these patients. Serum triglycerides can be high in these patients. That may not be in the early part of liver involvement, but later part during the disease with the liver involvement, you can see high triglyceride levels. So let's talk a little bit about the elevated ferritin level in these patients. So ferritin level can be greater than 10,000, although you will see the diagnostic criteria put for HLH in 2004 says greater than 500, but these patients have markedly elevated ferritin level. Macrophages are actually primary source of ferritin here, and when you see that high ferritin in a pediatric patient, it's very helpful in diagnosis. In adult, there are some confounding factors you have to keep in mind when you see high ferritin. So we are all aware of, although they are rare conditions, but hemochromatosis, and you can also see patients who have transfusional overload, like patient with sickle cell disease or myelodysplastic disorder, they have got multiple transfusions. But anytime you start seeing a patient who is very sick, critically ill, with multi-organ dysfunction, and do not have prior history of hemochromatosis or transfusion, you have to think of that it could be because of the activated macrophages. I was talking about one of my patient with macrophage activation syndrome with the hematologist, and the interesting comment I heard that anytime I have seen that high ferritin in a patient, the patient was having massive hepatic necrosis. So keep that in mind. What other things you will do? Since these patients are sick in ICU setting, they have multi-organ dysfunction, you want to make sure there is no infection, so these patients will get cultures of blood, bone marrow, urine, cerebrospinous fluid, and any potentially infected body fluid. Viral titers can be checked, serologies, which sometimes may be helpful, but sometimes you don't get too much help with that, or PCRs for different kind of viruses, including EBV, CMV, adenovirus, and whatever is suspected based on the epidemiology. Patients will undergo EKG, chest radiograph, and echo. This is very helpful in my patient with systemic JIA because those patients can have pericardial effusion. They just tell you that they are very sick and they are inflamed, and that can be part of their disease manifestation too. CSF analysis is needed, especially in patients with neurologic findings, and all you may find is cellular pleocytosis. You may find some hemophagocytosis there or elevated protein, but of course you want to culture the CSF and make sure that you're not dealing with meningitis. And check the virus PCR and the CSF simultaneously. If they have neurologic symptoms, you will do MRI, and MRI can show anything from parameningeal infiltration, subdural effusions, necrosis, to vasogenic edema in press. CT will be indicated if there is a high suspicion of malignancy, so you can do CT of the neck, chest, abdomen, and pelvis. Abdominal ultrasound may be needed if you are trying to evaluate for hepatosplenomegaly. Some of the immunologic testing, and these tests are not available in all centers. These are available in specialized centers. Some of the things you can check in every hospital, that will include the immunoglobulin level and the lymphocyte subtypes that you can easily do through the flow cytometry. But you may want to check these patients' NK cell function, especially for perforin and granzyme B. And that is a specialized flow cytometry you can do in the patient that you are worried that they may have a genetic susceptibility to develop HLH again. So this is the flow cytometry of my patient that I earlier presented. And you can see that the perforin and granzyme B activity is normal. And this test was sent as a reference lab to Cincinnati Children's Hospital. Bone marrow biopsy is something which is very helpful in these cases. And if there is a suspicion, we should have a low threshold of doing bone marrow biopsy to diagnose HLH. It's helpful because you will be able to culture bone marrow and rule out infection in patients with cytopenia, that what's suppressing the bone marrow. You should also be able to evaluate for possible lymphoid malignancies. And you can see those activated macrophages or hemophagocyte. There is a stain called CD163 that also can be done on the bone marrow, which is looking for the upregulation of or those activated macrophages in patient with MAS or secondary HLH. This is the hemophagocyte slide from one of the patient which was seen earlier on the medical floor here at LSU. And this was a 35-year-old patient who presented with fevers, cytopenia, high triglyceride level, and a ferritin level of 25,000. And this is the bone marrow biopsy showing the hemophagocytes. It's another picture. I wanted to put the report here because anytime when we're looking at the pathology reports, we have to have a visual experience of how it looks like. And this is how a patient with a positive bone marrow biopsy would be reported. And you can see that it says CD163 positive histocytes, several macrophages with hemophagocytosis. And you can also see their comment on the special stain, anti-CD163 positive. Slide, move 2 slides. Okay, so putting that all together, when will we start thinking of a patient having hemophagocytic lymphohistiocytosis? Think of that when patient have prolonged unexplained fever. Think of that when patient have liver inflammation. There is unexplained hepatic failure. Patients have coagulopathy or DIC-like picture, and we cannot figure out if there is any infection. Patients have cytopenias. Patients have high ferritin level, usually greater than 10,000. Sick patient with multi-organ dysfunction of any age, absence of leukemia and lymphoma, and patient look that sick. These are the 2004 revised diagnostic criteria for HLH. And you can see that there is mention of the genetic mutations that can be checked. Along with that, 5 out of 8 criteria that you want to see before you think somebody has HLH. That includes everything that we discussed, including fever, splenomegaly, peripheral blood cytopenia, hypertriglyceridemia or low fibrinogen, hemophagocytosis in the bone marrow, spleen, lymph node, or liver, low or absent natural killer cell activity. That's something you can do through the specialized flow cytometry, high ferritin, or elevated soluble CD25. How do you treat those patients when you see patient with HLH? Initial treatment is steroid, high dose steroid, IV steroids. Those patients will, if you catch HLH early and you use steroid, you may be able to improve outcome of that patient, and you may be able to control the disease very fast. Except in some cases, they may be steroid resistant, and they may need more treatment. And the treatment which is favored, at least in rheumatology world, is cyclosporin, because it stabilizes the T cells. So cyclosporin seems to do a better job in patient with macrophage activation syndrome. If the patient didn't respond to the treatment with steroid and cyclosporin, the next thing which can be used is something where we usually refer to our oncology colleague is using the protocol which is defined through HLH 2004. And that includes etoposide, dexamethasone with or without methotrexate, including intrathecal methotrexate. And that would be used in refractory cases. There is some role of use of IVIG. I didn't highlight it because this is a little controversial, that you can use in virus-associated reactive HLH. The problem with using IVIG in a patient who is in multi-organ dysfunction and renal failure is all the volume overload, and if they are in ARDS, you may worsen few things. So, but it has all the experiences anecdotal, and some authors have found it successful treatment of secondary HLH, especially the viral trigger. Rituximab, if there is a feeling that this is triggered through EBV, which it's the monoclonal antibody depletes B lymphocyte, may be useful in some patients. So the patients who have had this disease at a very young age or have had recurrence or who have a strong family history of that, they may be referred for the bone marrow transplant. And the time when you will refer them for the bone marrow transplant would include biallelic familial HLH associated mutations, genetic mutations, recurrent disease, or age less than 2. This is just a picture of that requisition form that you send to Children's Hospital Cincinnati, where they have a HLH Center of Excellence, where we can always direct our questions for refractory patients. And most of the pediatric patients who need the bone marrow transplant, they are referred there. And basically describes the HLH here. And here are the mutations that they can check. And in my patient, I got PRF1 checked because that's the most common one in African Americans. What is the challenge in treating those patients? I think the biggest challenge is delay in diagnosis, not knowing the disease. So there is a saying that eyes don't see what mind doesn't know. And if we are not looking for that disease, we're going to never diagnose those patients. And they may go into more and more multi-organ dysfunction. And then it's too late to treat them. So treating or diagnosing the disease in the timely fashion is the key of treating them on time. Use of immunosuppression in patients who already are having cytopenias, and we're talking about using chemotherapy medications, as well as hepatic dysfunction. Maybe something also in which we need more reassurance, but if we have had a formal evaluation, we will know we are dealing with that, and there is a need of it. There is fear of using immunosuppression when we think there is underlying infection. I was involved in one case, 10-year-old who had secondary HLH. And I remember critical care staff asking me, why would you not give steroid to this patient today? And my response was, can you tell me there is no hidden infection? And the patient was sick for a while, and then we did the further workup. And the previous workup has been negative for infection. So we decided we're going to go ahead and start with immunosuppression because the outcome was not looking good already. We know that there is significant early mortality after diagnosis, greater than 20% in HLH-94 trial. And I want to say the 1 to 2 cases per year I have seen of HLH, I have seen almost 50% mortality rate. There is need of immune testing and genetic evaluation to differentiate primary versus secondary when you think there is enough need. My patient was 15 years of age. Could not identify enough triggers. She might have systemic onset JIA. 1/3 cases do not develop arthritis till late in the disease. But that's why I did all the immune testing as well as genetic testing on that patient. So what happened with the patient that we earlier discussed? 15-year-old African American female presented with some wrist pain, tenderness, chest pain, intermittent fevers, and was given, I was found to have profoundly high inflammatory markers, LDH and ferritin. We treated with steroid, oral steroids, fever resolved, and then it recurred again, and now she was in hepatic failure. We treated that patient with high-dose steroid, IV pulse steroid for 5 days, and then was maintained on oral steroid, and oral cyclosporin was added. Patient fever resolved, her liver enzyme and coagulopathy gradually improved. She was later maintained on oral steroid and cyclosporin for almost a year. I gradually weaned off her steroid in 6 months, and then I weaned her off from cyclosporin during the next 6 months. I did the immunologic testing, flow cytometry, and it showed normal NK function for perforin and granzyme, and I showed you that. Her genetic testing was negative for PRF1 mutation. So this patient is asymptomatic for last 2 years now, and she's being followed in my clinic every 6 months now. So let's summarize what we learned from HLH discussion today is that we all need to be aware of the clinical manifestation of HLH. Why? Because this can present in any setting, and it can be triggered by infection, by malignancy, by rheumatology conditions, and these patients are very sick. It's aggressive and life-threatening syndrome in which there is excessive immune activation. It's common in infant and young children, but it can affect patients of any age. Patients can have predisposing genetic defect, or they can have another trigger like infection, malignancy, or rheumatology condition. And the patients that you see with cytopenia, unexplained cytopenia, and multi-organ dysfunction, we have to maintain a high index of clinical suspicion. And it's imperative to diagnose HLH early and start the treatment as soon as possible to improve the outcome. And I included the patient with a happy outcome compared to a lot of other patients that I have seen with possible secondary HLH, in which outcome or prognosis was very grim. This is my picture with my patient with juvenile arthritis, and I'll be happy to answer any questions. Yes?
I think your point about early diagnosis is important, but on the hematologist side of diagnosis, unless you see hemophagocytosis, it's not always so easy. Even those 5 out of 8 criteria can be confusing. If you look at why Eleanor Roosevelt died, she had biliary tuberculosis. They thought she had acute leukemia initially, and then they thought she had a pre-leukemia, and if this diagnosis existed, they might have thought that, and she had splenomegaly, and cytopenias. So you've got to be cautious. And so the reminder is when you're doing the bone marrow on these patients, always make sure you culture it as well, because sometimes you don't see the hemophagocytosis, and you're left wondering if somebody's saying, should we pull the trigger and give high-dose immunosuppressive? Well, we obviously don't want to do that if they have disseminated granulomatous disease.
Yeah, and most of the time as a rheumatologist, I get involved at the time when there is infectious disease, have looked at the patient, and we have pan cultured and done a lot of workup on the patient. And that's why I think the treatment challenges are there. We need a lot of reassurance, definitely, that we are not immunosuppressing a patient who may have active infection. So on the other side, I have a lot of patients who are immunocompromised patients, and they come with different kind of infections, and I have to still use the immunosuppressant, and that time I would want them to stay on the adequate antibiotic coverage before I start doing that. So if we can find hemophagocytosis, and in 60% cases you may, but in 40% cases we still can miss, then I think the other thing would be to carefully look for infection first and cover for infection before we start embarking on the immunosuppression therapy. I agree with that.
So if you have a patient with the sepsis and the multi-organ dysfunction syndrome, and something is leading you to this diagnosis, and you just get the ferritin, and the ferritin comes back over 10,000, would you go ahead and start treating them with immunosuppressants without doing the bone marrow biopsy, flow cytometry?
So I think if they have a known condition, like systemic GIA, like lupus, the condition in which we know there is uncontrolled inflammation, which is the possible trigger, yes. So if you see HLH in a setting where you're habitual of seeing it, then you may go with the treatment and do immunosuppression. But if you have a patient in which you don't know what might have triggered it, you have to be more careful. And then you have to do more workup and make sure you find evidence, which may be bone marrow biopsy, which may be repeating another bone marrow biopsy, or maybe even doing a lymph node biopsy, looking for other areas, rather than just starting the immunosuppression right away. But if it is a patient who is known to have systemic GIA, known to have lupus, or uncontrolled inflammation, then I may feel comfortable starting immunosuppression because I know this is MAS, or macrophage activation syndrome, that I'm dealing with. Any more questions? Okay, thank you for coming.